Dear students, the topic of our lecture is halitosis, and the plan of the lecture is the following. Halitosis, its definition, actuality, prevalence. Biochemical basis of halitosis or odorants. Classification of halitosis. Etiology and pathogenesis of halitosis. Methods of diagnostics and differential diagnostics of halitosis. And of course, prevention and treatment of this pathology. But what does this word halitosis mean? Halitosis is medical term for bad breath or for an offensive foul breath odor. Halitosis is a widespread problem in the general population. Prevalence of halitosis is about 50-65% in Europe, more than 30% in United States of America, and between 30 and 65% in Russia. Therefore, the problem is rather important. The source of halitosis is volatile substance which may be smelled by a person, and person feels bad smell, bad odor. These sources of halitosis are named odorants. And odorants are divided into three groups. Main odorants are divided into three groups. Volatile sulfur compound such as hydrogen sulfide, dimethyl sulfide, methyl mercaptan, amines such as putrescin, cadaverine, and organic acid, for example, butyric acid. And as I have said before, all these substances are volatile or flammable. All these substances may be transformed into gas and go into the air. But where is source of halitosis? Where are the odorants hidden in our body? Mainly in our oral cavity. Local causes or our oral cavity takes 90% of all cases, and reasons outside the oral cavity take just 10%. The origin of halitosis is often occurring on the dorsoposterior region of the tongue and or dental plaque in interproximal areas of molars. Anaerobic microorganisms of tongue coating produce odorants which dissolve in saliva. When there is too much of odorants in saliva, they convert in gas and go to the air, and we can smell it. Speaking of halitosis, we use some terminology and classification. You can see the classification and part of terminology on the picture. At first, halitosis may be real or true or genuine halitosis, and this kind of pathology includes physiological and pathological halitosis, and also halitosis may be psychogenic or untrue. And psychogenic halitosis, when obvious malodor is not perceived by others but the patient complains of its existence. Psychogenic halitosis is divided into pseudohalitosis, when no objective evidence of malodor but the patient thinks that they exist, and halitophobia. The patient persists in believing that he or she has halitosis despite firm evidence for the absence of objective evidence. The patient usually has embarrassment and problem with interpersonal social communication. True halitosis, as I have said, may be physiological and pathological. Physiological halitosis when the patient does not have pathology in oral cavity or outside the mouth. Pathological halitosis when the patient has some problems in oral cavity or outside the mouth. For halitosis, which caused by some extraoral reason, we can also use term blood-borne halitosis. Some words about etiopathogenesis of physiological halitosis. Anaerobic microorganisms produce odorants. They are growing in tongue coating. Therefore, tongue coating is the first source of physiological halitosis. Do you remember about 90% of local reason or for local reasons? Okay. Formed by anaerobic microorganisms, chemical substances dissolve in saliva. When there is too much of odorants, they convert in gas and go to the air, and we can smell it. The causes of physiological halitosis are poor oral hygiene, hypopitulism or deficiency in the salivatory rate, diet, smoking, stress. Therefore, physiological halitosis may be the consequence of lifestyle. Halitosis as a result of the ingestion of certain food and drinks such as spices, garlic, onion, cabbage, radish, or some bad habits such as smoking tobacco or drinking alcohol, and this halitosis is usually transient, often caused by sulfur-containing volatile substances, and it is considered to arise both from intraoral and extraoral regions. Breath of jungle is the example of physiological halitosis. During the night, salivation decreases, and in the morning, breath is bad. There are some drugs that predispose to the occurrence of halitosis. Antibiotics, corticosteroids, antihypertensive drugs, antihistamines, antidepressants, anticholinergic drugs, diuretics, and anticonvulsants. Pathological oral halitosis develops when patient has some oral pathology, for example, periodontal pathology, carious teeth and poor quality restoration, dental plaque under the orthodontic and prosthetic construction, xerostomia. Pathological extraoral halitosis develops when the patient has some extraoral pathology. The first source of bad breath is the respiratory pathology, such as sinusitis, cleft palate, tonsillitis. In this case, we are speaking of extraoral non-blood-borne halitosis. The malodor also may be emitted from the lungs and originated from disorders anywhere in the body, called extraoral blood-borne halitosis. The main causes of pathological extraoral halitosis are the following: pathology of upper respiratory tract, we have said about it, pathology of the gastrointestinal tract, liver disease, renal failure, diabetes, helminthosis, radiation therapy, and some others. In some cases, depending on the smell of the patient's breath, the dentist may suspect a likely cause for the problem. For example, fruity breath may be a sign of uncontrolled diabetes. An urine-like smell, especially in a person who is at high risk of kidney disease, can sometimes indicate kidney failure. And as we have considered earlier, there are some drugs that predispose to the occurrence of halitosis in patient. Yes, the same as in case of physiological halitosis. The drugs act in two ways. At first, they may be turned into odorants, or they can decrease the salivatory rate, and odorants from oral cavity may go into the air. A problem of diagnostic of halitosis is that a person may not always know that he or she has bad breath. This phenomenon is because odor detecting cells in the nose eventually become accustomed to the constant flow of bad smell from the mouth. Therefore, other people may notice halitosis and tell to this person, but person does not know has he or she halitosis or not. And we can diagnose halitosis in two ways, subjective and objective. And it is very interesting that subjective diagnosis of halitosis is better than objective, because halitosis at first social problem, the problem of social relation. The patient does not suffer from halitosis, his relatives and friends suffer. The best diagnostic of halitosis is diagnostics by relatives. When somebody who is very close to you and can smell you in different situations, smell your breath and say you, have you halitosis or not. Also, we can use self-diagnosis. And for self-diagnosis, patient can use, for example, spoon test, napkin test, or floss test. Spoon test. A plastic spoon is used to gently scratch the lingual dorsum to collect epithelial cells and microbial biofilm. And patient sniffs the spoon from the distance of 5 centimeters. Of course, we can ask other person to smell, to sniff the spoon. Napkin test is very similar to spoon test, but we should use a napkin. And floss test is the following. The patient is asked to floss his molar teeth, and then patient or clinician or some other person sniffs the floss from 3 to 5 centimeter distance. Objective diagnostics of halitosis includes the following methods: assessment of concentration of volatile sulfur compounds using a gas analyzer, gas chromatography of saliva, microbiological studies to identify the bacteria associated with the development of halitosis. All these measures are available, but they are not used in routine clinical practice as they are expensive and time-consuming. Among recent ways of diagnostics of halitosis, we can mark gas analyzer halimeter, which allows us to estimate the concentration of volatile sulfur compounds in breath. But our breath, our exhaled air, contains not only sulfur compounds, but also amines and some organic acids which cannot be detected by this apparatus. Therefore, this way is also not optimal way of action, way of diagnosis. For differential diagnosis of halitosis, we should divide exhaled air to oral, nasal, and pulmonary air. What for what for it is important to find the localization of the source of halitosis. The exhaled air from our nose contains nasal air and pulmonary air. Therefore, air from our lungs and air from our sinuses, and air from oral cavity contains oral air, nasal air, and pulmonary air. Therefore, if nasal air is good and exhaled air from oral cavity is bad, the reason is in oral air. Therefore, the patient has oral halitosis. But for example, if both exhaled air from nose and exhaled air from oral cavity are bad, we should distinguish nasal and pulmonary air. In this situation, we ask patient to wash oral cavity with chlorhexidine solution and then exhale air very quickly, and in this situation we can take pulmonary air. Now let's consider the treatment of halitosis. Treatment of physiological oral halitosis consists of the following steps: toothbrushing and flossing training of a patient, mechanical removal of tongue coating, professional oral hygiene, use of mouth rinses, dietary recommendations, cleansing the mouth after eating dairy products, fish, meat, garlic, onion, coffee, tobacco, and regular visits to dentist. There are many different tools for mechanical removal of tongue coating on the market. A tongue scraper can only remove the upper surface layer of the biofilm. The effect of a tongue scraper is shorter in duration than the effect of a tongue brush. But it should be special, soft brush. We cannot use common toothbrush for this purpose because we can damage the tongue. Moreover, cleaning too hard with a tongue scraper or with a firm brush is a risk for tongue injury. Any kind of electrical device for professional tongue cleaning is not recommended because of the risk of traumatic injury. Animal experiments have shown that mechanical injuries of the tongue may be carcinogenic. Therefore, detailed and comprehensive tongue cleaning instructions are necessary for our patients. Tongue cleaning should be carried out gently, with low force, at the posterior part of the tongue dorsum. The lateral borders should not be cleaned because of the risk of traumatic injury. And please keep in your mind that chronic trauma of the tongue may be contributing factor for oral cancer in future. Also, of course, we can recommend our patients to use antiseptics in dentifrices or dentifrices with deodorizing effect. The most common antiseptics in mouthwash are chlorhexidine, triclosan, and cetylpyridinium chloride. These antiseptics have bacteriostatic effect on anaerobic microflora which produce odorants. Chlorine dioxide and hydrogen peroxide have rather short effect. Very interesting effect of zinc. Zinc react with volatile substance and they are not volatile more. And combination of low concentrations of zinc and chlorhexidine seems to be the most efficient way to remove the volatile sulfur compounds that causes halitosis, bad breath. Urea or carbamide, which may be found in pastes and gel, decrease pH level and therefore create bad environment for anaerobic odorogenic microflora. Treatment of pathological oral halitosis is treatment of oral disease, and this treatment includes professional oral hygiene, periodontal surgery, removal of destroyed teeth, correction of xerostomia. Xerostomia is deficiency of salivatory rate. And also treatment of pathological oral halitosis may include using of oral irrigators. Now some words about treatment of extraoral halitosis. The role of dentist is to refer patient to other specialist. Treatment of extraoral halitosis is treatment of some somatic disease, which is the reason, the cause of extraoral halitosis. About pseudohalitosis and halitophobia. First of all, the patient should believe us, and we should feel empathy and create trust relationship with the patient. Anyway, we should investigate the exhaled air. Why we should investigate the exhaled air? At first, the patient may have transient halitosis. Therefore, the patient may come to us without bad breath, but maybe the patient has jungle breath, or the patient has halitosis after food with garlic, but during the visit the patient does not have halitosis because the lifestyle of the patient is changing during the day. And secondly, part of patient may be sure that they have halitosis due to hypersensitivity, due to pathology of olfactory structure in the brains, and in this situation we should suppose it and refer patient for the necessary doctor. If all investigations are negative, we should reason the patient, we should explain the results of investigation. And just if everything is useless, we can advise consultation with psychologist, because sometimes halitosis is psychological, psychogenic problem, and we cannot do anything with halitophobia. This problem requires help of special doctor, help of psychologist. I hope that the lecture was rather interesting and the information is useful, and thank you very much for your attention.